Cases EM Quick Hits podcast. Quick, let's get on with it. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for general information and educational purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. Unless stated otherwise, the opinions expressed by the hosts or guests are made in their individual capacity, not on behalf of the Institute nor Medicine Cases. The EM Cases Summit this past November brought together more than 600 people from over 30 countries for the ultimate online EM conference. The feedback we got was unreal. There were so many folks who said that it was the best EM conference they've ever been to. If you missed it, no worries. For a limited time, you can get streaming access to all the main stage talks of all 3 days through emcasessummit.com. And not only the 2024 summit, but we're also offering 50% off for streaming packages of the 2023 and the 2021 summits as well, all with full CME accreditation. So please do help support EM Cases to continue to be free open access, and head over to emcasessummit.com to purchase your very own EM Cases Summit video streaming package for a peak educational experience. First up, we have Swami, who's going to introduce us to the idea that there might be a better way to time the administration of RSI medications, and that timing them in just the right way might improve outcomes. He, by the way, gave a mind-blowing talk at the summit on what to do when your vasopressors aren't working as expected. All right, take it away, Dr. Swaminathan.
Rapid sequence intubation, RSI, is a specialty-defining procedure for emergency medicine and resuscitation. The simplest definition of RSI is the near simultaneous administration of an induction agent and a paralytic, rapidly resulting in ideal intubating conditions. Over the last 5 to 10 years, we've made a number of improvements in the way that we do RSI. Much of this has been focused on the preparation and tube delivery. Resuscitate prior to intubation. Improve hemodynamics to decrease the risk of peri-intubation hemodynamic collapse. Improve oxygenation to increase the safe apneic time. One of the big keys this last year has been the pre-oxy study, which basically tells us that we should be doing non-invasive for pre-oxygenation in all of our patients before we proceed down that pathway for RSI. We've spent lots of time talking about positioning, airway alignment, ramping, bed up, head elevated. We've talked tons about the bougie first approach. Another consideration that doesn't get as much attention is the sequence with which we give those drugs. Typically, as we stated up front, it's near simultaneous administration of the induction agent and the paralytic agent. One of the things that we're always keeping in the back of our heads is that we want to make sure the patient is induced before they are paralyzed. We want to minimize the chance for that paralysis while aware. But I think we have to be a little bit more nuanced with how we are giving the medications and really think about the onset of action of our drugs. If we're using succinylcholine as our paralytic, we're typically getting an onset time somewhere around 45 to 60 seconds, and rocuronium at the high dose, 1.2 mg per kg, is going to give us a pretty similar time of onset, just around 60 seconds. Most of our induction agents work considerably faster. Etomidate has an onset of action around 30 to 40 seconds. Ketamine, probably around 30 to 45 seconds. Propofol can be as little as 20 or 25 seconds. That means that if you are pushing your induction agent and your paralytic agent simultaneously, it's a virtual guarantee that you're going to have an induced but not paralyzed patient. That means that you may have a patient who is apneic but has muscle tone, making it very difficult, if not impossible, to deliver the tube. Now, that might only be for 20 seconds, but it could be up to 30 seconds of time where the patient is apneic but not paralyzed. The ideal that we should be shooting for is simultaneous onset of action of our induction agent and paralytic agent, not simultaneous administration, simultaneous onset. In order to do that, we have to give our paralytic agent first, followed by our induction agent. And there is some data telling us that this is a safer approach. A 2019 secondary analysis by Driver and colleagues found a 6-second faster delivery of tube in patients where the paralytic was administered first. 6 seconds, not a whole ton of time, but still, it shows that that is the better approach. In 2024, Driver and a bunch of colleagues published another paper which found an association between paralytic first and a lower first attempt failure. Of course, with that paralytic first approach, we are concerned about having the patient who is awake but paralyzed, but the data, again from Driver and colleagues, shows that it's probably an overblown risk in terms of RSI. More important is to prep our post-intubation sedation and analgesia package. You should have that ready to go before you are pushing your rapid sequence intubation meds. Based on everything that we know, I think there are two approaches that are reasonable in rapid sequence intubation. You can give both of your medications simultaneously, understanding that you are likely going to have a period of time where the patient is apneic, but you can't place the tube because they aren't paralyzed. In order to make that a safe situation, you have to be supplying some breaths during that apneic period of time before the patient's paralyzed. Now, that could be the pre-oxy approach where you've got non-invasive in place with a backup rate to continually deliver breaths, or you can do bag valve mask ventilation during that apneic period. The other approach is simply to understand the onset of action of your medications and time your drugs. I've been doing this for years and it's not that hard to get done. The key pieces are 1, having a stopwatch with a second hand, and 2, the physician should be pushing the medications. My standard set of meds for intubation are rocuronium and ketamine. I'm going to give my rocuronium at time 0 and start my stopwatch. At 20 seconds, I'm going to push my ketamine. That ensures that both meds are going to kick in right about the same time, and it's going to give me the ideal intubating situation while minimizing the time that the patient is apneic but not paralyzed.
That's definitely a game changer for me because I've always thought that pushing the paralytic first runs a high chance of paralyzing the patient while they're aware. But if you time it right, that is the rock followed by 20 seconds, then ketamine, it sounds like you avert that dreaded awake paralysis and provide the best intubating conditions for success. Thank you so much, Dr. Swaminathan. All right, next up, I had the pleasure of speaking with Dr. Brittany Ellis in anticipation of the International Conference of EM in Montreal at the end of May this year. We're going to feature 3 speakers at ISEM on EM Quick Hits over the next 3 months. Here is our conversation with Dr. Brittany Ellis. We're all, unfortunately, very familiar with ED boarding and crowding. And we've dedicated entire EM Cases episodes to this topic in particular. But in our extensive discussions on the causes and solutions of ED crowding and boarding, we didn't get a chance to dig into the issues surrounding boarding of older patients. And I suppose it goes without saying that we're seeing more older patients with more complex medical problems with each passing decade. And with the baby boomers soon becoming octogenarians, the problem around boarding older patients, these problems are just going to get more and more important to understand and have solutions for. So with the goal of elucidating the key issues around boarding older patients and discussing some potential solutions so that we can ultimately save more lives and morbidity, not to mention dignity for our older patients in the ED, it's my pleasure to introduce a new guest to EM Cases, Dr. Brittany Ellis. Welcome to EM Cases, Dr. Ellis.
Thank you so much. It's a real pleasure to be here.
Dr. Ellis, you have a very impressive CV. I'll just try and summarize it here for our listeners. So Dr. Ellis is the Saskatchewan Provincial Lead for Geriatric EM at the Saskatchewan Health Authority. She's an emergency physician in Saskatoon. She did a Master's of Science in Public Health at the University of Edinburgh and her EM training at the University of Ottawa with a fellowship in geriatric EM at the University of Toronto. Dr. Ellis is also the current chair of the Canadian Association of Emergency Physicians, that's CAPE, the Geriatric EM Committee. And this year, CAPE is hosting the ISEM, the International Conference of Emergency Medicine in Montreal, May 24th to May 28th. So I thought I'd highlight some of the best of ISEM before it even happens. So this is sort of a flipped classroom affair. So that when you go to ISEM with the hundreds of your EM colleagues from around the world, you'll get even more great meducation out of it. So let's start with why should we care about ED boarding older patients in particular? Now, older patients are particularly vulnerable to the adverse effects of ED boarding. So let's think about what the adverse effects of boarding are in general. There's things like delayed care, there's prolonged waiting times, there's the physical and psychological stress of being in a busy, chaotic environment. So, Dr. Ellis, in what ways is there a disproportionate impact of ED boarding on older patients?
Yeah, I mean, as you stated, we all know the ED is a super tough environment. It's noisy, bright, at times total chaos, and sometimes it's even hard to think, never mind sleep. So imagine you came to the ED, you have dementia, you're hard of hearing, you've been feeling unwell for a few days, your reserves are already low, and now you find yourself in an unfamiliar, overstimulating, busy environment. You're overtired, you don't know if it's day or night, you aren't moving, you aren't sleeping much, you're struggling to advocate for yourself. It's probably no surprise that you're at a high risk of adverse events, including things like developing delirium, experiencing further functional decline, things like pressure ulcers, and more. And ED boarding can worsen all of these. The longer the stay, the greater the risk of developing adverse outcomes and exacerbating underlying conditions, especially if you're older.
So you mentioned delirium and pressure ulcers. Could you just give our listeners a sense of the prognosis once an older patient has delirium? I mean, we've talked about this before, but I just want to kind of remind people that delirium is not a light diagnosis, that it does have a high mortality. But could you just maybe give us some numbers about pressure ulcers and delirium?
Absolutely. Well, when it comes to delirium, I think, we know that many older people, 30 to 40% that come through our EDs have delirium. And we also know that we're missing probably 90, 80, somewhere around there % of these, and that these are also being missed as inpatients. And this leads to increased morbidity, increased mortality, increased hospital length of stay, increased risk of dementia in the long term. There's all sorts of adverse outcomes of developing delirium and missing delirium in the emergency department. And you mentioned pressure ulcers, or I mentioned pressure ulcers. And I think what we don't realize is that pressure ulcers can start with such short periods of time of immobility. Laying on a stretcher for an hour can start to lead to skin breakdown. Pressure ulcers, which can last very protracted courses, very protracted lengths of time. We're talking months, years, even more, depending on the underlying condition of the patient and their wellness. So these can have really long-term devastating consequences and can lead to longer hospital stays, but also lead to more frequent ED visits in the short term. Again, kind of exacerbating what we're already talking about, those, capacity challenges and boarding challenges.
Yeah, there's that irony that you said with both delirium and pressure ulcers that they actually both lead to longer hospital stays. So, the problem of crowding is because of long hospital stays that we can't get patients upstairs. So we're just exacerbating the exacerbator. All right. So that's a bit on how ED boarding has a disproportionate impact on older patients. Let's talk about crowding and access block, which I just alluded to. How does having older boarded patients disproportionately impact crowding and access block in particular?
Yeah, I mean, I want to start by being really clear here. Older people are not the cause of our capacity challenges, and they are not the cause of access block. Instead, they're victims of it. The cause, as we all know, and I'm sure you've talked about on your show before, and I know you've talked about on your show before, are complex and largely exist outside the emergency department. However, the care that older people get in the ED and the ED environment alone contributes to challenges and conditions that prolong their length of stay, worsen crowding, and worsen capacity. Conditions like we just mentioned, delirium, malnutrition, falls, functional decline. So in other words, older people may be boarded in the ED as a result of systemic overcapacity, but the boarding experience itself leaves them requiring longer stays and thus also contributing to access block and capacity issues. It's that vicious cycle you talked about. I kind of think of it like a fire producing its own fuel. It's just going to keep on burning.
I feel like I've got a pretty good understanding now of the issues and problems of boarding of older patients. Let's move on to some of the potential solutions. And I'd like to break this down into systemic solutions and local solutions. Now, some listeners might be thinking that overcrowding really is purely a systemic problem. Really it's all about access block. and that there's little that we can do in the EDs to solve the problem of access block. Let's just put that aside for a moment, because as you'll see, I think there are things we can do in the emergency department that can have a significant effect on crowding. So let's talk about both the systemic and the local solutions. So what are some of the systemic solutions that we can advocate for to relieve bed block for older patients? There's things like geriatric-focused hospital teams, having dedicated geriatric units or step-down units. There's improved discharge planning for older patients. There's prioritizing at-risk older patients for admission. How does all this work to relieve bed block and improve outcomes? And how can we advocate for those things in particular?
Yeah, sure. I just want to start by agreeing with you, but also saying that I think there are things we actually can do while we're working in the emergency department that have small impacts on access block. And I think we'll hopefully come to those later. But when it comes to the system, I actually like to start briefly outside the ED, because while I know we're all ED focused, we got to take the blinders off and think that the capacity challenges can be affected by prevention. When I think of prevention, I think of enhancing services that prevent people from needing to come to the ED in the first place. That may look like improved access to home care services, physiotherapy, occupational therapy, and timely access to appropriate care, whether it be primary care, specialist care, such as geriatricians, falls clinics, memory clinics, and more. So if we start with thinking about what's going on outside the ED, that can impact, like we said, preventing coming into the ED, and also maybe our ability to discharge people back home from the ED if they can have that timely access to services and have services that are appropriate to their needs. But shifting our eyes from the community and back into acute care, there's a few things I think a lot about. One of them that I don't hear a lot of discussion on is the use of electronic health records and AI, and how maybe we can better use these things to prioritize admissions and bed assignments. So we know older people are one of the populations that have increased risk of adverse outcomes when they're boarded in the ED. This leads to longer hospital stays. So just try to get them out of the ED faster, whether that's home or in many cases as an admission, instead of using things like time-based or service-based or geographical-based admission criteria. What if we were to utilize a risk score to help us prioritize bed assignments? We can get older people out of the ED and to a ward where we can prevent things like deconditioning, delirium, and other complications that often arise that are specific to the ED environment. I think that we collect enough information in most electronic health records that that sort of thing could be automatically generated. So, for example, if a patient presents to the emergency department and their presenting complaint is generalized weakness and they're 85 and they're on 15 different medications, that's all information that's electronically available and could be taken and put into a risk calculator, as could their vital signs. When a patient's admitted, this score is automatically generated, and admission coordinators, nurse navigators, whoever the people are that help us prioritize admissions, can utilize that information to better assign beds.
That's a little bit about a couple of the systemic solutions. Anything more in terms of systemic solutions?
Absolutely. Overall, I think we need to focus on more geriatric care. The beauty of geriatric care is that a lot of times you say, well, we don't have geriatricians in our hospitals, or they don't come to the emergency department, or those sorts of things. But this is something that we can provide in a variety of ways. In a large academic tertiary care center, for example, there may be geriatric units, there may be geriatric consults in the ED. And these have been shown to lower rates of delirium and lead to better functional recovery. But smaller centers, they might instead employ a more interprofessional approach, maybe implementing something like the Hospital Elder Life Program or HELP program, where the focus is on improving mental and physical activity across units. And it doesn't require so much as specialized individuals like geriatricians, but more of a team-based, knowledge-based approach. This could be in person. This could maybe be a blended model of in-person and virtual care, depending on the resources in the community. But the goal is really to have more geriatric-focused care. I also think focusing on better communication across the healthcare continuum is important. We've all had patients who come to our EDs who are complex, maybe have had a recent consult, a recent discharge, and we can't get that information. It's not available to us. When that person is older, on 12 medications, has a list of comorbidities, the impact of not having this information can be even more significant. So I think having hospitals and healthcare systems that are invested in better communication and care tools and protocols that work between EDs, inpatient care, and community settings is detrimental to enhancing the care of older people in particular. And finally, I really think we need to focus on improving our discharge planning and communication. Evidence suggests that if we start discharge planning early in the admission process, in fact, as soon as they set foot in the ED, we're more likely to avoid admissions, to get patients home, and to reduce the likelihood of prolonged boarding. So these teams that can focus on older people and enhancing their discharge, often called GEM teams, JETI teams, nurse navigators, whatever they are. But the important thing is that they really focus on effective and sustained discharges. It links back to better, timely, appropriate community services and care records, all of the things I talked about. And just before I stop, there's actually one other thing, and that's alternate models of care. We know that home hospitals or hospitals at home, where we provide effective community care in the home, are both cost effective and in line with the goals and wishes of many older patients. And there's probably way more of this that we can do in alternate models, such as transitional care spaces, which are proactive, dedicated environments that can exist in things like a care home and focus on functional recovery and transitions home. So again, the goal is to start this process and this planning and this communication as soon as an older person sets foot in the ED, and to continue that all the way back to their home environment.
Do you know, is there any data showing that it's actually cost effective to employ any of these programs?
Absolutely. Most of the data comes from Europe, and particularly some of the Scandinavian countries where this is a really often employed model of care, hospital at home, or having, for example, funding that people living in the community can determine how that funding is best utilized to support their care needs. So, rather than saying it costs $8,000 to $10,000 a month for an older person to live in a nursing home, recognizing that they may be able to do that and provide a better environment for themselves in their own home while using a similar or likely smaller amount of money. And the data really does exist to support these arguments. One of my favorite books, and I'm not putting a shout out specifically, but Neglected No More by Andre Picard really highlights a number of the challenges and opportunities using data to support these types of changes.
Fantastic. All right. So those are some of the potential systemic solutions for ED bed block related to older patients. Let's move on to the local factors. What can we do in our EDs to improve flow of older patients? For local solutions, I've read about things like prioritizing quieter rooms in the ED for older patients. I mean, that sounds like something simple that could probably be done in most places. Early mobilization with ED physiotherapists, again, to avoid those pressure ulcers. Implementing triage protocols for older patients. There's delirium prevention measures like providing familiar objects and reducing noise and having ED geriatric support teams. I imagine a lot of these things can be done by volunteers, which a lot of hospitals have. What are some of the key evidence-based local solutions for improving geriatric ED flow and outcomes for older patients in the ED?
Yeah, so I think you mentioned a number of great things. Starting at triage, we know that older people often present differently to our younger populations for a variety of reasons. And in recognition of this in Canada specifically, and for those countries who utilize the CTAS system for triage, a modifier was introduced, commonly called a frailty modifier. This was implemented and introduced in 2016. And despite it being nearly a decade old now, which shocked me to think, but nearly a decade old, it's not in routine use in a number of emergency departments in Canada. So that would be a great step, is just starting off by implementing these tools that already exist within our frameworks that we're already utilizing. Beyond things like the CTAS frailty modifier, there's a number of scoring systems and protocols that can help us recognize older people who are more likely to return back to the emergency department or to have bad outcomes. Things like the Inter-IED screener, Prisma, frailty scoring, or various delirium screeners. And again, these can really be best utilized using some of the information and electronic tools that we already have in our emergency departments. You also mentioned delirium, and we've talked a little bit about delirium today. Not only does it lead to increased hospital length of stay and short-term risks, it also leads to long-term risks like dementia and mortality. But the good news is that it's preventable, and the prevention starts in the ED. There's a lot of evidence to show that we miss delirium, but there's tools that help us diagnose delirium better in the ED, and they're really short. We're talking seconds to perform them. Things like the delirium triage screen or the brief confusion assessment method, which are both, when used together, very sensitive and very specific. Two things we like in the emergency department. They're both validated for use in the ED as well. And beyond diagnosis, we need to think about prevention. And we know with good evidence that multi-component delirium prevention is effective. Unfortunately, we've not been able to isolate the single magic bullet that helps prevent delirium. And that's why we say multi-component. But the good news is a lot of this prevention work is just good care. It's giving special attention to things like mobilization, nutrition, sleep, reorientation, all the things that I think we wish we could do better and can really do better in our emergency departments. Overlapping with delirium is a focus on early mobilization and with physiotherapy whenever possible, because we have systematic level evidence to suggest that this decreases hospital-acquired disability, reduces falls, it improves patients' quality of life, and it decreases hospital length of stay. So mobilizing early and mobilizing with people like physiotherapists is an effective and important part of care of older people in the ED. Beyond mobilization and delirium care, we really need to think about what we're doing with the patients when they're in the ED. Now, you mentioned trying to put them in a quiet room. Absolutely. This, though, as you know, is a challenge in many instances. There should be options to prioritize space distribution and utilization in the ED. So rather than putting an older person in a hallway or corridor bed, they should be prioritized for a bed with doors, a window, lights, etc. And rather than moving older patients around your department, which we know increases the risk of delirium, they should be prioritized to stay in a single treatment space as long as possible. We appreciate, and I appreciate, that sometimes we just medically have to move patients for a variety of reasons, but really paying attention to who we're moving and why we're moving them can help to improve the care of older people, reduce the risk of delirium, and enhance their stay. And I think lastly, overlapping with some of those systems level changes we talked about is the timely access to specialist care and services such as geriatricians, geriatric focused teams, etc., to assist in managing older patients quickly and effectively in the EDs. And this has been shown to reduce the amount of time that older people stay in the ED. This could be, again, in person or virtual or in a combination method. But with a number of RCTs, we know that geriatric consultation models lead to fewer complications and shorter ED stays by up to 20% in the ED, which is a significant amount of time I think we can all appreciate.
Fantastic. Wow, 20%. That's impressive. The nice thing about some of the things that you mentioned was that some of them really are very simple. I mean, some would require things like AI, sure, but there's other things that, just having a volunteer just hang out with them and provide them something familiar to them would help to decrease the rate of delirium, for example, which would decrease length of stay, which would then improve overcrowding. So just really simple things that we can do that I think can really help. So I hope our listeners come away with a deeper understanding of crowding and how it impacts older patients in particular, and that we've hopefully inspired some folks to advocate in their EDs and in their hospitals to bring some of the solutions we talked about to the table where they work. So thanks so much, Dr. Ellis, for your thoughtful insights, and looking forward to hanging out at ISOM in Montreal in May.
Awesome. Thank you so much, Anton.
A word from our sponsor, Metricaid, the experts on scheduling systems. Since 2015, I've been using Metricaid, the incredible self-scheduling system that has made my life and the lives of my colleagues so much easier. Metricaid can really help minimize the drawbacks of shift work we all know so well. by not only ensuring equitable distribution of shifts, but also integrating circadian rhythm-friendly recovery time into their algorithms. They minimize my sleep deprivation, which allows me to be a better EM doc on shift. I can take better care of my patients and still have energy left after my shifts to enjoy other aspects of my life. Check out metricade.com/EM cases for more details on how this awesome scheduling system works. Next up is Dr. Dave Jerome, one of our wilderness medicine experts and the brains behind the totally excellent Drowning Quick Hit. If you haven't heard that one, please do check it out. This time, he's going to give us some clinical nuggets of wisdom on patients who've had a tourniquet placed for a prolonged period of time.
Our department has seen a few cases recently where patients have arrived with tourniquets that have been on for many hours. Over the next few minutes, I'm going to share one of these cases with you, and then we'll go over the key clinical pearls of managing patients who present with a prolonged tourniquet time. The case is a 30-year-old male who was shot in the leg. Police put on a tourniquet at the scene within a few minutes of the injury. This occurred in a remote rural community, and by the time the patient arrived to us at the regional trauma center, the tourniquet had been applied for 9 hours. On our initial assessment, the patient was hemodynamically stable. His hemoglobin was 115. He had a metabolic acidosis with a pH of 7.22, and his potassium was elevated at 5.6. When we spoke with our vascular and ortho surgeons, they asked us to take the tourniquet off and to send the patient for a CTA. So with what you know about this case, would you agree to take the tourniquet off right away? And if not, why not? There's strong evidence that tourniquets are both effective and safe when used in the right context. It's generally accepted that tourniquets are safe if they have been applied for less than 2 hours. Beyond 2 hours, there are two competing concerns related to the prolonged tourniquet time. The first is that the longer a tourniquet has been applied, the higher the risk of permanent damage to the hypoxic tissues distal to the tourniquet. And the second concern is that the longer a tourniquet has been applied, the higher the risk of precipitating a reperfusion syndrome by taking the tourniquet off. Once a tourniquet has been applied, we want to try and take it off as soon as we can to limit tissue damage from the ischemia. Most tourniquets can be successfully converted to some other form of hemorrhage control, such as wound packing or direct pressure. But if we're within the time frame that we're worried about a reperfusion syndrome, then we don't want to take the tourniquet off until a patient is in a place where they can be monitored and treated for the elements of reperfusion syndrome. Reperfusion syndrome is a constellation of features associated with the immediate return of blood flow to the cold and ischemic tissues which had been sequestered by the tourniquet. There are 4 key elements to reperfusion syndrome. First is metabolic acidosis from the washout of lactic acid. Second is cardiac arrhythmias due to hyperkalemia and that metabolic acidosis. The third is hypothermia, which occurs both from the return of cold blood that was sitting behind the tourniquet, and then also from the cold limb acting as a continual heat sink as it is reperfused. And the fourth is hypotension, from suddenly increasing the area that the circulating volume needs to perfuse. Of course, all of these are things that we want to avoid in the context of trauma. In patients with tourniquets who are at risk of reperfusion syndrome, we should pre-treat the patient before taking the tourniquet off. And the way we do this is to treat for each of the elements of the reperfusion syndrome separately. For metabolic acidosis, we can pre-treat with 1 amp of sodium bicarb given 5 to 10 minutes before the tourniquet is released. For the cardiac arrhythmias, we can shift serum potassium with IV insulin and dextrose. Our goal here is to get the serum potassium level to a low normal level, around 3.5 millimoles per liter, before the tourniquet is released. We can also stabilize the myocardium by pre-treating with 1 gram of calcium gluconate 2 to 3 minutes before the tourniquet is released. Once the tourniquet is released, the patient should be on cardiac monitors and have defibrillation pads on. For the hypothermia, we should pre-warm both of the patient's core and the tourniqueted limb. And for the hypotension, we want to resuscitate the patient before the tourniquet comes down so that their blood pressure is high enough to accommodate the anticipated drop. These elements of reperfusion syndrome and reperfusion resuscitation are summarized very well by two Australian doctors named Drs. Weinrock and Peters in a tool that they call the Reperfusion Toolbox. We'll link to that resource in the show notes. When thinking about taking off a tourniquet, the first step is to check for any contraindications. The three absolute contraindications to tourniquet removal are 1. If the patient is already in shock. 2. If the tourniquet is controlling bleeding from an amputated extremity. And 3. If it won't be possible to monitor the patient after the tourniquet comes off. For example, if the patient is about to be transferred to the OR or sent for a CT. If there are no contraindications, the next step is to risk stratify the patient based on how long the tourniquet has been applied. This will give us a sense of both the urgency of taking off the tourniquet and the risk of reperfusion syndrome. If the tourniquet has been on for less than 2 hours, then the tissue in the limb is assumed to be salvageable. There's also a minimal risk of reperfusion syndrome at this point, and so we don't need to take any extra measures to treat or monitor for it. Our goal is to try and take all the tourniquets off within this 2-hour time frame. If a tourniquet has already been on for 2 to 6 hours, the limb is likely experiencing permanent damage from ischemia, so we want to prioritize taking the tourniquet off as soon as it is safe to do so. However, we also need to expect some element of reperfusion syndrome. So before releasing the tourniquet, these patients should be in an environment capable of cardiac monitoring and administering ACLS medications. It's reasonable to consider pre-treating for some of the elements of reperfusion syndrome, and we must be prepared to treat for all the elements of reperfusion syndrome in case they develop after the tourniquet is taken off. If a tourniquet has been on for more than 6 hours, we're in the time frame where we expect there's already likely been significant ischemic damage to the limb. We're also expecting significant reperfusion syndrome. In other words, we're expecting minimal benefit but significant risk in releasing a tourniquet after 6 hours. These tourniquets should only be taken down once the patient is in a critical care environment and after the patient has been pre-treated for all the elements of reperfusion syndrome as discussed. Coming back to our case, remember that this patient arrived with a tourniquet that had been applied for 9 hours already. He was hemodynamically stable, but he was already acidotic and hyperkalemic. We did not send him for the CTA as requested. Instead, we kept him in the ED and we pre-treated him for reperfusion syndrome. He was then transferred directly to the OR where his tourniquet was taken down without incident. So the next time you're managing a patient who has a tourniquet on, assess for the 3 contraindications to tourniquet removal, which are 1, the patient is in shock, 2, the tourniquet is controlling bleeding from an amputated extremity, and 3, it wouldn't be possible to monitor the patient after the tourniquet comes off. Consider the 3 windows of prolonged tourniquet time, which are less than 2 hours, 2 to 6 hours, and more than 6 hours. And remember the elements of reperfusion syndrome and how we can treat each one. Give sodium bicarb to manage acidosis, give calcium for cardioprotection, shift the potassium down to 3.5 millimoles per liter, warm both the patient and the limb, and make sure the patient's blood pressure is high enough to accommodate for the anticipated drop.
Wow, another fantastic quick hit from Dave Jerome, beautifully explained and perfectly summarized. Next up is Nour Khatib, our rural EM host. She's going to go through a case where a peer support program was involved. Now, in our next Quick Hits podcast, number 63, I'll be interviewing Dr. Kylie Booth, the medical director for the Ontario Peer-to-Peer program, to talk about the program itself in detail. But to kick off our series on rural peer support programs, Dr. Khatib's going to give us a little bit of a description of how peer support programs work and go through a great case with one of the peer-to-peer physicians.
Hello, everyone. Welcome to another EM Cases Rural Quick Hit. Today's a special one. It's a nostalgic one for me, as it reminds me of why I went into rural medicine right after residency. You can't deny it. The first year out of residency is a lot, nerve-wracking. June 30th, you're excited to graduate. Life's good. You're going to run this ship. No reviewing, no questions. You're ready to be released into staffhood. July 1st, you realize, oh damn, you're running this ship. Your signature is the only one at the bottom of those charts. What better way to get over this fear than through practicing and putting yourself in a rural and remote area as the only physician in town? That's what I thought. I thought this would be great. It was in the end. But flooding is how I approached this. So flooding, aka exposure therapy, arguably doesn't work for everyone. You learn a lot rurally. You learn to hone those clinical skills. You gain confidence, but remain humble when you realize quickly that it feels uncomfortable and very lonely. Nowadays, when I'm in the comfort of my large community hospital site, Markham Stouffville Hospital, I'm practically rubbing elbows with colleagues, specialists. Help is almost always readily available. Hey, can I show you this elbow x-ray? Hey, take a look at this ECG for me. What would you do with this kid? Those are questions we hear every day from colleagues. At a rural site, where most emergency doctors across Canada work, they do not have the luxury of elbow support. What's the next best thing? Emergency medicine ED peer support programs. These programs provide coaching and support for emergency physicians 24 hours a day, 7 days a week. Physicians can get immediate, on-demand coaching and support from credentialed ED peer physicians by phone call or video call. Now, across Canada, these programs have been popping up, such as the Rudy program in BC, Viper in Saskatchewan, and over the last 2 years, the ED peer-to-peer program in Ontario. I'm one of the ED peers at the ED peer-to-peer program in Ontario, and you can reach us by calling Critical and asking for an ED peer. You will immediately be connected to an ED peer any time of day from any emergency department across Ontario. Whether you need help with a big trauma case, need help reviewing an ECG, or even just want to talk about a case you saw weeks ago, we are ready to answer the call with, how can I help? There is no hierarchy here. We are peers helping one another out and recognizing the constraints of limited resources in these rural settings or any setting. Today, I've invited one of my colleagues from the ED peer-to-peer program, Dr. Phil Gillick, to go through an ED peer case with us. Welcome, Phil.
Thank you very much, Nour. I'm very happy to be here and talk about a case where peer-to-peer really shone through.
That's awesome. So tell us about your case.
So I was working an evening shift and at about 1 o'clock in the morning. So at 1 in the morning, I got a phone call from a newly graduated physician. He actually graduated only 23 days ago. And he was now working in a single coverage rural site in the Northern Ontario. And he had a case of persistent lactic acidosis in a 67-year-old woman who was otherwise healthy. And he asked for some advice as to how to parse the situation and what the further workup should be. So this lady was 67. She was healthy. She showed up with a history of diarrhea and feeling mildly short of breath. The doc did a very thorough workup. So he asked all the right questions. He asked whether there was cough or sputum, whether there was any other signs of upper respiratory tract infections, whether there was any fevers, chills, and there was none of that. There was no chest pain. There was no pleuritic pain. There was no abdominal pain. There was no nausea. There was no vomiting. There was no melena, and there was no bright red blood per stool. So a little bit puzzling and not much to go on. In the later digging, it did show up that a patient had a plane flight of about 4 hours or so, about 2.5 weeks ago. When we were reviewing her physical exam, she was mildly tachycardic, but otherwise had normal vitals, and a completely non-contributory exam, so neurologically intact, normal heart sounds, clear chest, normal abdominal exam, and nothing focal on the GU exam. The doc did what he could at his site. So he did a chest x-ray, which was normal. He did an ECG, which he told me showed a sinus tachycardia. He did a full panel of blood work, including troponins, and they were all normal except a VBG, which showed a lactate of 8 and a corresponding drop in the bicarbonate and a mild acidosis with a respiratory compensation secondary to that.
You did mention some blood work there. What is typically available in that rural site that he was calling you from? Put us in context. How many nurses does that physician work with? What size of hospital are we talking about? And how far away are we from a CT scanner?
Yeah, so this really varies between these sites. So the normal setup of a rural hospital, and I work rurally as well, just like you, Nour, so I have a good understanding of the settings that these folks call from, is, especially on a night shift, somewhere between 2 to 4 nurses. Most of the time, there is no respiratory therapy. Often the blood work is call-in, so you have to call in the lab person to do the lab work, and that can mean a significant delay as well. And ditto for the x-rays. Often the x-rays after hours are a call-in, so again, that can induce a delay. And there is also a limit to how often you can call these peoples because of budgetary concerns. So certainly it is a resource-restricted environment. In this particular case, the doc did have a CAT scan and advanced imaging available at site. That has been one of the good things that has happened over the last 20 years. There has been a proliferation of CAT scanners in the rural departments, although staffing radiologists to read those CAT scans in the middle of the night remains a significant challenge.
All right, great. So what happened next? What did you guys do about this lactate of 8?
Well, we kind of scratched our heads together. And I think that's the value of the peer-to-peer program. Did it have somebody who's not there, who hasn't been, on shift for 12 hours and has a bit of a fresher brain? So we went about it systematically. We reviewed the medications first to see if, for example, this patient was on metformin or another medication that could cause a rise in the lactate, and she wasn't. I also mentioned to the doc that lactate is one of those values that often has a fairly wide range when it's measured in the lab, and especially when it's done, as it was in this particular case, with point-of-care testing. I know that in our system, in my rural hospital, our point-of-care testing can be off by as much as 30%. So I asked for that lactate to be redrawn, and it came back similarly elevated. We thought about dehydration because the lady did have diarrhea. So the doc on site has already started some rehydration, and there was a plan that we agreed to continue. So to give this lady a couple of liters of normal saline and then to redraw the lactate and see if it goes down. And we did that initially, but unfortunately, the lactate persistently stayed high. So we had to zoom out again and look wider. And at the end, we settled that basically this lady must have some kind of tissue hypoxia that's driving this lactic acidosis. And then I asked him, you mentioned that she was a little bit short of breath, anything at all that he could notice and that is off with her respiratory status. And he then did mention that he had a hard time getting SpO2 initially. So he has put her on 2 liters of oxygen, and she's now reliably sitting in the 96, 97, 98%. And that was a clue for me, because here's a lady who is otherwise healthy. She's 67. She had clear chest and a normal chest x-ray. She should not need to be on oxygen. It really should be about 100%. So I asked him to show me her ECG, because he did mention she had a bit of a tachycardia. And when we looked at the ECG, I saw that she did have some signs of the right-sided strain. So she had a right axis deviation, she had a right bundle branch block, she had the sinus tachycardia, and then she had some ST depressions anterolaterally, which made me think. We again reviewed the history, and that's where the plane flight came up. And again, a moderately long plane flight 2.5 weeks ago. It's not the strongest risk factor for a PE, but that was the only thing that we had. The doc on site took a look at her calves and at her legs and noted no sign of an active DVT, but we agreed to do a D-dimer. And while we're doing the D-dimer, we did a bedside focus echocardiogram. So I coached the doc how to do that. We took a look and we decided that her RV was looking reasonable, her LV was looking reasonable. So we said, we're going to go ahead and give her a little bit more fluid while we wait. Significantly later in the night, I got a phone call again from the doc. So he said, hey, this D-dimer came back significantly elevated. It was over 4, so there would be 4,000 in some of the scoring systems for D-dimers, which was a very significant elevation. So the doc on site proceeded to talk with his radiologist, who then approved CTPA. The CTPA showed a very large PE with signs of right-sided strain. And one of the other things that we added to our plan was to repeat the troponins in 3 hours after the initial evaluation, so to see whether there has been any evidence of troponitis and heart strain. And in fact, the second troponin was elevated. So now we have a diagnosis of essentially a submassive PE causing some troponitis, causing some right heart strain in a rural place with no ICU and no internal medicine on site.
Wow.
So how this case ended, just to give a bit of closure first, is the doc on site had a discussion both with the ICU internal medicine and his referral center, which is some hours away, and then had a discussion with a patient. And the patient decided that she did not want any transfers and she did not want any aggressive care. So she did not want a TNK, although in all honesty, given that she was not hypotensive or on pressors, she probably didn't need it to begin with. So what was decided is that she's going to get started on subcutaneous enoxaparin and she was going to get admitted locally.
Phil, any key takeaways from this case?
As far as the learning points, I would say that, again, a few things that stood out for me is that people with healthy lungs should not need oxygen. This is something that is really abnormal. And if you do have a healthy person who needs to be on a couple of liters of oxygen, then we really need to take a very careful look at their lungs, at their heart, with x-rays, with clinical exam, with bedside ultrasound, and if necessary, with advanced imaging to figure out why they need to be on oxygen. Second one is knowing the subtle signs of serious conditions on ECG really does pay off. That's one of my areas of expertise in teaching, is all these subtle findings where ECG can really come through for you. And a simple thing as a right axis deviation in a person who has otherwise healthy lungs, is not a smoker, doesn't have sleep apnea, could be the clue that you need to cinch the diagnosis. And then finally, when you don't know what's going on, going back to the baseline pathophysiology and figuring the story out from the first principles. In this particular case, the fact that lactic acidosis meant that simply anaerobic metabolism was happening. And once we excluded all the other causes, we settled down on tissue hypoxia as the likely driver of the lactic acid production.
Fantastic points, Phil. Let's remind ourselves of the ECG signs for PE. ECG changes associated with acute pulmonary embolism may be seen in any condition that causes acute pulmonary hypertension, including hypoxia, causing pulmonary hypoxic vasoconstriction. Some ECG signs we're all taught sinus tachycardia, the most common abnormality, but it's only seen in 44% of cases with PE, so keep that in mind. Complete or incomplete right bundle branch block, which is only seen in 18% of cases, and right axis deviation, which is seen in 16% of cases. And of course, the often taught S1Q3T3 pattern, which you saw, Phil, in this case, but it is neither sensitive nor specific for PE. The ECG for this case will be available in the show notes. Phil, it was absolutely wonderful having you here on another EM Cases Rural Quick Hit. We're going to have more EM Cases Rural Quick Hits discussing ED peer-to-peer programs. Thanks for coming on, Phil.
Thank you for having me.
Do you dread doing your clinical notes every shift? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. Notes are written in your style and ready the moment the patient encounter is over. Just imagine leaving work at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence can't replace you, but it can do the administrative work that no human should be subjected to. All the magic happens in just a few clicks so that you can spend less energy on charting and more time on doing what you do best. Freed learns your style over time, just like a human scribe, and it'll never quit on you. More than 6,000 of your clinician colleagues already use Freed AI. Get back to spending your clinical time caring for patients and let Freed AI do the rest. Head over to getfreed.ai and use the code EMC50 to receive $50 off your first month with Freed. That's getfreed.ai with the code EMC50.
You're looking at an ECG of a patient with chest pain, and you notice that there's anterior ST elevation, but no inferior ST depression. Does this represent acute coronary occlusion? We often rely on reciprocal ST depression to confirm ST elevation MI. But some acute coronary occlusions have ST elevation without ST depression on the 12 lead. Others have minimal ST elevation with ST depression. And others only have ST depression on the 12 lead without any ST elevation. So how can we use reciprocal change to identify acute coronary occlusion? Think of reciprocal change as a mirror. First, what are you looking at, and which is the mirror image? You don't want to mistake the mirror for the image that it's reflecting. ST elevation might just be the mirror image of secondary ST depression. Abnormal depolarization, like LVH or left bottom branch block, produces discordant ST depression and T-wave inversion in the left-sided leads of V5 and V6, with expected mirror image ST elevation in V1 and V2. Or ST elevation might be the mirror image to nonspecific primary ST depression. ST elevation in AVR is the mirror image of global subendocardial ischemia, which is a high-risk but nonspecific pattern. What we're looking for is primary ischemic ST elevation or hyperacute T waves from acute coronary occlusion, and its mirror image ST depression and T-wave inversion, which may be more obvious. Secondly, remember where the mirrors are. The Pales mnemonic teaches that posterior produces reciprocal change anterior, which produces reciprocal change inferior, which produces reciprocal change lateral, which produces reciprocal change septal. This makes the ECG seem like a confusing house of mirrors with a maze of reflections, and it doesn't work for mid or distal LAD occlusions that have anterior ST elevation without any reciprocal ST depression inferiorly, like our patient. This can lead to delayed reperfusion for LAD occlusions even when they meet STEMI criteria. Instead of an abstract and error-prone mnemonic, just remember how the leads relate to the heart and which leads mirror each other. Just like X-rays have two views, so do ECGs. The limb leads represent the frontal plane, up, down, left, right, and the chest leads represent the horizontal plane, from the right anterior V1 to the left lateral V6. In the limb leads, there are two pairs of mirrors. The high left lateral lead AVL and the right inferior lead 3 mirror each other. And the lower left lead towards the apex, lead 2, is mirrored by lead AVR. In the chest leads, there are also two pairs of mirrors. The right anterior lead V1 and the left lateral lead V6 are mirrors to each other, and the anterior leads V2 to V4 and the posterior leads V8 to V9 are mirrors to each other. Now that we know what we're looking for and where the mirrors are, we can identify patterns of acute coronary occlusion, including where there is no mirror image on the 12 lead, or when there is only a mirror image. In inferior occlusion MI, there may be minimal ischemic ST elevation and hyperacute T waves, but the mirror image, ST depression and T-wave inversion in AVL can help identify these subtle occlusions. Just as in subtle high lateral occlusions, there's often more obvious mirror image inferior. In posterior occlusion MI, the 12-lead ECG only shows the mirror image, with primary ischemic ST depression in the anterior leads V2 to V4. And because these leads are closer to the heart, the mirror image on the 12 lead is usually more obvious than the tiny posterior leads. Conversely, the mirror image to anterior ST elevation is not inferior, but posterior ST depression. This explains why mid-LAD occlusions will not manifest any ST depression on the 12 lead. Distal LAD occlusions can even produce anterior and inferior ST elevation and be mistaken for the diffuse ST elevation of pericarditis. Where the Pales mnemonic accidentally works is for LAD occlusions proximal to the first diagonal, where there is ST depression inferior, but this is the mirror image to subtle ST elevation or hyperacute T waves in the high lateral lead AVL. Or LAD occlusion proximal to the septal branches, where ST depression in the left lateral V6 is the mirror image to ST elevation in the right anterior lead V1. So to identify acute coronary occlusion, don't rely on STEMI criteria or the presence of both ST elevation and ST depression on the 12 lead, and forget about the Pales mnemonic. Instead, look for primary ischemic ST elevation and hyperacute T waves. Remember which leads are reciprocal to each other, and use mirror images to identify occlusion MI. This includes anterior STEMI from mid-LAD occlusion without mirror image on the 12 lead, posterior MI with only mirror image ST depression on the 12 lead, or subtle inferior, subtle lateral, or subtle proximal LAD occlusions where the combination of subtle ST elevation and mirror image ST depression can help you find subtle occlusions. To see multiple examples, go to the latest ECG cases blog on EM Cases. This is the first in a series of posts on the art of occlusion MI, or how we can use visual concepts to identify acute coronary occlusion, and how art explains the science of occlusion MI. And for online, live, and interactive ECG courses, visit heartsecgcourse.com.
That, of course, was ECG Cases Hearts course guru, Dr. Jesse McLaren. There's an online advanced EM Hearts course that runs over 2 days, February 12th and 19th, and it's timed so that both Australians and North Americans can attend. And there's an in-person advanced EM Hearts course at EMU in Toronto. And for residents, there's an in-person EM resident course at ICEM in Montreal. So if you're heading to EMU or ICEM, you can learn from Dr. McLaren in person. It's a super interactive course, not just a series of lectures, really high-yield education at its finest. All right, to carry this EM Quick Hits home, as part of our Best of the University of Toronto Emergency Medicine series, it's my pleasure to have Dr. Melody Ng, a colleague of mine at North York General Hospital, who's going to give us some really practical tips, do's, and don'ts when it comes to the why, when, how, and what we should eat and drink as shift workers. And now for the best of University of Toronto emergency medicine. There exists widely known data that suggests the following. As shift workers, we're at increased risk for cardiovascular disease, for cancer, and for depression. Much of this has to do with sleep, which we'll dive into in another series of EM Quick Hits, but some of this has to do with what we eat and drink and how we eat and drink. And we've all probably felt hangry, hungry and angry on shift, and lose our ability to focus when we neglect to eat and drink sensibly. Part of reducing these risks of MIs, strokes, cancer, and mental illness is eating and drinking sensibly before, during, and after shifts. So the question is, how do we do this right? Well, to answer this question and keep EM providers from being hospitalized patients, we have my lovely EM colleague who, before becoming an ED doc, did a degree in nutrition and has given great talks on nutrition for EM docs, Dr. Melody Ng. Welcome, Dr. Ng.
Thank you.
All right, to kick off, I'd like to start with a bit of pathophysiology just to sort of lay the foundation of recommendations that we might make a little bit later in this podcast segment. The first question is, what do we need to understand about how we metabolize food and drink as shift workers to inform what we ingest before shift, on shift, and after shift?
Yeah, so this all hinges on understanding what's called the enteric nervous system, something actually known as the second brain of our body. Now, we all know about the central nervous system, but the GI tract also has hundreds of millions of neurons, and it coordinates and collaborates with the central nervous system. This is called the gut-brain axis to regulate metabolism and many other things. But today we'll just focus on the metabolism part. So why is shift work so hard on the body? What does it disrupt? I think we all know that it's our circadian rhythm. And the circadian rhythm is so important and really deserves our respect. In a nutshell, it's a 24-hour cycle that encompasses our sleep-wake time, release of hormones, our metabolism, blood pressure, body temperature, you name it. Now, the input into the central nervous system to tell it that it's daytime is the sun, right? The sun hits the retina and it tells the suprachiasmatic nucleus in your brain that it's daytime. Now, the input to the enteric nervous system is food. So guess what? If you come home at 2 a.m. in the morning, you're tired, you're hungry, you decide to wolf down a big meal and then sleep, you're actually sending mixed signals to your body of when it's daytime because your central nervous system knows it's night, but the gut is seeing food. So that ends up sending confusing signals to the rest of the body. and leads to metabolic derangement. The term in research, in the literature that I've seen, is called the misalignment of your central and peripheral circadian rhythm, which leads to chronic disease, especially diabetes. So the bottom line is you don't want to be eating in the middle of the night. In addition, your appetite regulating hormones are completely out of whack when you're sleep deprived. So your leptin, which is an appetite suppressant, goes way down when you're sleep deprived. And your ghrelin, which is a hunger hormone, shoots way up. So what happens is that you might feel like you need to eat, but it's actually not an accurate reflection of the calories that you need. So you end up eating more than you should. Now, unfortunately, a bit more bad news before we get to the good news. Studies show that after even just one night of shift work, you're more insulin resistant. And maybe just a quick review of insulin resistance. We all know that the pancreas secretes insulin to regulate blood glucose. But when your peripheral tissues don't respond to that insulin, the beta cells of the pancreas have to work harder to secrete more. This is called insulin resistance. And eventually, the pancreas fatigues. And this leads to diabetes. So insulin resistance is a precursor to diabetes.
That's incredibly well explained. I totally get it. You mentioned eating a big meal in the middle of the night is not a good idea, and a little bit of why. I want to dig a little bit deeper into that, of the timing and the size of meals. Some people eat a few little meals, instead of having 3 big meals a day, they'll have 10 little meals and snacks a day. Some people try to have breakfast, lunch, and dinner kind of consistently, but that's kind of impossible as a shift worker. Why does the volume and timing of what we eat matter? And what do you recommend in terms of the volume and timing of what we eat?
So I think you've totally hit the nail on the head. Timing is everything. Numerous studies, in particular high quality of evidence, randomized controlled trials, when they compare shift workers who eat during all their shifts, including nighttime, and those that work the same shifts but restricted eating to daytime, there was better health outcome if they ate only during the day. I mean, everyone's different in terms of how long they can go for without eating. I think that has to do with your energy and your metabolism. You probably don't want to be too hangry when you're seeing patients, but at the end of the day, it depends, how much you should eat probably depends on when your shift ends, right? If it ends in the middle of the night, then you don't want to be eating a meal at that time. But if it ends during a normal meal time, then of course you can eat. But we'll talk more about it actually. Another thing to be aware of in terms of timing of eating is that your insulin resistance varies throughout the day. So why that's important is that you should always watch what you eat, but it's more important sometimes than others and some days than others. And knowing that variation can really help you know when you have to be more or less careful. So if you're not diabetic, you're less insulin resistant in the morning and more insulin resistant as the day goes on. If you're already diabetic, you're actually more insulin resistant in the morning and less as the day goes on. And as I mentioned earlier, if you are sleep deprived, you've done a night shift, your insulin resistance is actually much higher than your baseline. And so that's not the time for a cheat meal or a treat meal. Got it.
You've talked about diabetes, and I always hear the term glycemic index coming up over the last decade or so. It seems like, I hear things like, that what you're drinking there has high glycemic index. You shouldn't be drinking that. What is glycemic index? Why should we care about it? And why is it especially important for shift workers?
Yeah, so let's define glycemic index. It's a number between 0 and 100 that indicates how quickly and how high a food will spike your blood glucose. So pure glucose is 100, and everything else falls below that. So why does this matter? It's basically an estimate of the stress a food or a meal will put on your pancreas to secrete enough insulin to regulate your blood glucose. Okay, you can imagine if there's a huge spike very fast, your pancreas is going to have to work overtime to regulate. So it's not the only way to judge a food in terms of its healthiness. There are some foods that are higher glycemic index that have other important nutrients that you can eat, but it's just something to be aware of. There's also, you talked about volume of food earlier. There's also the concept of glycemic load, which is a factor of both the glycemic index of a food and the number of carbohydrates. So this doesn't mean, therefore, that high glycemic index foods are always off limits. You can have a higher glycemic index food, but in smaller portions, and that can still be very manageable for your pancreas. For example, watermelon, right? It's high glycemic index, but if you have a small amount or overall there's not that many sugars in watermelon, it's still a healthy food to have.
Essentially, we should try and avoid a high glycemic load, so a large volume of high glycemic index foods.
Exactly.
and we should try and avoid high glycemic index foods in the middle of the night when we get home from a shift at 3 or 4 in the morning. Okay.
When you're more insulin resistant.
Got it. Yeah. So if you could just give us sort of a list of kind of the most common high glycemic foods.
Yeah. So my rule of thumb is that the more processed a food is, the higher the glycemic index. Because you think about it, they've taken out the fiber and they've added in sugar. They've added in preservatives to make it something that they can package and sell to you, right? So it's convenient. And unfortunately, protein bars kind of fit in this category. We all like to reach for a protein bar during a shift, but I would think twice, to be honest. And there are other healthier options. So generally, foods that have a good amount of healthy fats and fiber and protein are lower glycemic index. So I can give you some examples. So let's say bread. Sourdough bread is lower glycemic index than white bread, which has no fiber. If you think about snacks, popcorn is lower glycemic index than, say, cornflakes or any sort of breakfast cereal. Breakfast cereals are marketed as healthy. They're really not. They have no fiber. They have added sugar. And actually, all this information is Googleable. They're on the Diabetes Canada website, or you can just Google and look and compare foods. Even amongst healthy foods like banana, for example, a green banana is low glycemic index because it has more fiber. But as it ripens, when it gets to that stage of being yellow with the brown dots, that's actually high glycemic index because all the fiber has converted to simple sugars. And so that will spike your blood sugar way higher, way faster than a green banana. So it really depends on the food, the ripeness level of the food, and something you can look up. Chicken, beef, fish, eggs, they all have a glycemic index of 0 because they contain either none or very little amounts of carbohydrates.
All right. So eat apples instead of bananas?
or a small amount of banana.
Or a small amount of banana. Okay. I can just see people chopping up their banana into little pieces and trying to preserve the banana just
savor it. Enjoy every bite.
All right. So now I understand about glycemic index, some of the foods that are high in glycemic index that you want to avoid in the middle of the night, or you want to avoid having huge loads of really anytime.
Wanted to mention one more thing about if you wanted to eat high glycemic index foods, for sure the portion is an issue. But also another thing to keep in mind is that you can pair foods to create an overall lower glycemic index meal. If that makes sense. Yeah. So let's say you really want to eat pasta and you don't want the whole wheat pasta. You want like the white, refined, processed pasta, the stuff that really tastes good.
Oh, yeah,
okay.
That's good.
You can have that. But first of all, be conscious of the portion size, but also pair it with high amounts of fiber. So vegetables like broccoli, healthy fats like an avocado or olive oil, and protein. And if you pair those things together, that all slows the absorption of carbohydrates and the subsequent spike in your blood glucose. That's actually, why the Canada Food Guide, I don't know if you're familiar with the Canada Food Guide. It's a government resource that aims to provide evidence-based guidelines on eating. It no longer talks about food groups and servings. I mean, I could never keep track of how much a serving was, but now it talks about plate proportions. If you look at your plate, half of it should be vegetables and fruits, which are high in fiber. A quarter are your whole grains, and a quarter is your protein. And so that really helps you build a meal that may have some high glycemic index foods, but you can balance it out. Now, let's say you hate vegetables. If you don't want to eat vegetables, I also have a way to cheat for you. The key word is seeds. Chia seeds, flax seeds, and psyllium fiber are all easy ways that you can add fiber to your diet. You can add it to your smoothie, to your soup, to your oatmeal, whatever it is. But that helps with regulating your blood glucose and reducing your cholesterol as well.
All right. Balanced life, balanced food on the plate.
There we go.
Got it. I want to talk a little bit about my favorite drug in the universe, which is caffeine. Many of us love caffeine. Some of us are dependent on caffeine. Some of us will go into withdrawal if we don't have caffeine. In Michael Pollan's latest book called Caffeine, How Caffeine Created the Modern World, he talks about the science of how the drug has evolved to addict us, how, interestingly, the Industrial Revolution, according to him, would not have occurred if it wasn't for caffeine. And then he talks about sort of the best timing of drinking coffee after you wake up to maximize your focus and attention, and gets into a lot of the science of caffeine. I personally, again, think that caffeine is one of the greatest drugs ever. It seems relatively safe. It makes me feel great, and it tastes good too. What does the evidence show when it comes to caffeine's ability to, A, help us focus and concentrate? And I guess the second part of the question is, how best should we use caffeine as a shift worker? Like, what are some of the important advantages and disadvantages of caffeine, the timing of caffeine, et cetera?
Yeah, I mean, I love caffeine. I tell my husband it's my elixir of life. Like I could not function without caffeine. And I think a lot of us are that way. A lot of us like our coffee. I mean, I do too. But actually, I personally find that the evidence and my personal experience shows that matcha is really great before shifts. It's a green tea powder. And the thing with matcha is that, like coffee, it's rich in antioxidants. But the more important thing is that it contains an amino acid called L-theanine. So what L-theanine does is that it gives you that Zen feeling, that sort of calm alertness. Now with coffee, you get that sudden rush where you feel on top of the world and then you crash very quickly. But if you want something that lasts a little bit longer, and also actually the evidence shows provides some cognitive enhancement, matcha's the winner. So they've done studies where they compare if people consumed placebo, caffeine, L-theanine, and a combination of both caffeine and L-theanine, which is what's in matcha. And then they administered cognitive tests. And actually, the group that got both the caffeine and the L-theanine did much better. So, honestly, something that gives me a feeling of Zen and cognitive enhancement, that's a yes, please on shifts.
Yeah, I've recently developed GERD, and coffee is one of those things that make GERD worse. So I tried switching to matcha, which has less GERD effects.
Less GERD-y.
It's less GERD-y, exactly. And I have to say that sort of calming effect that it has, you don't get any of that jitteriness that you get with a huge Starbucks, what are they called? Grandes or whatever the huge one is called. Yeah. It really is great, especially on shift, because, it's pretty stressful on shift. Our anxiety levels can go up quite easily on shift. And this really does kind of keep you feeling calm. And like you said, the evidence would suggest that it actually helps you concentrate better. So
absolutely. That's what I love about it. One quick note, though, is that if you're tempted to add dairy to your matcha, there's some evidence that that would actually inhibit the antioxidant effect. So what I do instead is add some non-dairy creamer. Coconut milk.
Nuance
milk.
there.
Yeah.
Okay. Great. The only problem with matcha I find, or matcha, however you want to say it, is that it doesn't taste close to as good as a good coffee. I mean, not even close.
You got to make some sacrifices in life, right?
Okay, fair enough. Anything else about caffeine that we should know? Timing of caffeine. I mean, I've heard some people say, "Oh yeah, I can't drink caffeine after 12 midday because it'll keep me up at 10 p.m." Other people say, "Oh yeah, I can drink a gallon of coffee and go straight to sleep." What does the science say in terms of the timing of coffee, the volume of coffee, or caffeine in general?
Yeah, I think there's a bit of a trial and error. Obviously, everyone's different and you develop tolerance. If you've not had caffeine for a couple of days and you have it again, you probably notice the immense kick that it gives you. So I don't think there's a one-size-fits-all answer. It really depends on the person. I personally cut it off after 12 p.m. at noon and trying to avoid it. I mean, the nice thing about matcha is that it lasts for a few hours longer, the alertness, than coffee. And so I can just have it at the beginning of a shift and not have to top up as much midway through. And that way I'm not still having caffeine in my system when I'm trying to wind down to sleep.
And just in case people are wondering, neither of us receive any funds from matcha companies.
No.
Okay.
That would be nice. No.
All right. Let's talk about what to do when you get home after a shift. I mean, you've already mentioned that we shouldn't be having any high glycemic big meals in the middle of the night because we want to try and make our meals regular, breakfast, lunch, dinner regularly. What do you suggest we actually eat when we get home in the middle of the night after a shift or early in the morning? What are some healthy choices?
Yeah. So the key is it depends on what time you get home and how much sleep you've gotten, right? You might get home during daytime and you're like, okay, this is a normal time to eat, but you were just up all night, which remember we said that actually increases your insulin resistance. So that's when you have to be a bit more careful. If you come home and it's normal daytime eating time, then sure, go ahead and eat normally. If it's nighttime, my personal rule of thumb is to hydrate before reaching for food. Because as I mentioned, your hunger hormones are out of whack when you're sleep deprived. So if you're up late working, but also, if you're up late working, you're running around, talking, sweating, you're losing moisture. And so often our bodies can confuse thirst and hunger. So what I try to do is actually hydrate first. My personal favorite is carbonated water. So something with a bit of flavor that makes me feel some satisfaction, but there's no sugar or sweetener added. And then if I absolutely want to eat, some of my easy go-to snacks are a handful of nuts, which have, fiber, healthy fats, a boiled egg. Actually, don't underestimate the power of a simple boiled egg. An egg contains all 9 essential amino acids. It contains vitamin D, it contains choline, which is a great nutrient for your brain. And so that can actually pack in a lot of nutrients and make you feel full enough to fall asleep without having to carb load. Other things I like is a bit of cheese or avocado. And then, obviously if it's daytime, I'll eat a more normal meal, but that's usually what I reach for.
That actually segues very nicely into, I have to admit that especially during the COVID pandemic, I got into this horrible habit of cracking a beer when I got home from a shift. Sometimes you're kind of really wound up when you get home from a shift and you want to just kind of mellow out and settle down, and cracking a beer. And somehow the beer, because you're, like you said, you're often thirsty and a little bit dehydrated when you get home. That beer was nice for the thirst and
hits the spot.
It just hits the spot. Could you comment just a little bit on the use of alcohol for shift workers?
Right.
I know Canadian guidelines have recently changed to say that we shouldn't be drinking alcohol at all.
Right.
It used to be 14 drinks a week for men and 7 or 10 drinks per week for women was deemed acceptable / healthy for the average adult, according to the Canadian guidelines. What's your take on alcohol use, in particular for shift workers?
Yeah, I mean, alcohol is a beloved drug. I hesitate to say anything about it, but I will. I think the most attention that has been put towards the red wine and the polyphenols and the antioxidants. A lot of people say that, oh, well, that's healthy for you, right? So that's fine. And actually, the one that we keep hearing about is resveratrol in red wine. But in terms of the ability of that to reduce the risk of cardiovascular disease, the evidence is actually quite weak. And exactly as you said, Anton, actually, WHO recommendation is that no amount of alcohol is safe. And I think especially for shift workers who are already at a higher risk of cancer, we know that alcohol is classified as a group 1 carcinogen by the International Agency for Research on Cancer. And this puts it on par with things like asbestos and tobacco and radiation. And so that's just something to be aware of. I find that, yes, alcohol can help you wind down, but it also disrupts your sleep. It makes you feel more relaxed in the moment. You fall asleep, and then it leads to frequent wakings, and you end up having quite fragmented sleep. So it's a bit of short-term gain only. You have that initial relaxation, but you pay for it later. But I think at the end of the day, you weigh the risks and benefits of any choice personally, right? Is it something that you find beneficial for your mental health or the social context that makes drinking more enjoyable? You can't avoid every risk in life. But I think there are some alternatives, if you're looking for a way to wind down. Things like chamomile tea, lavender tea, they're not as potent as alcohol, but they can also help you relax. Meditation, listening to boring stories on apps, these are all things that help. Personally, what do I like to do? We talked about this. I like to sing. So it's something that encourages deep breathing. It releases endorphins, maybe not too loudly at 2, 3 a.m. in the morning, but there are other ways, to unwind other than alcohol that will not be damaging to your health.
Wonderful. I like that idea. Singing. We probably don't do enough of it. Yeah. So I was telling you about how I got into this horrible habit of cracking a beer every time I got home from a shift during COVID. So then what I did during COVID was I had a bit of extra time. And instead of doing that, I built a sauna in my backyard. Nice. And now instead of drinking a beer when I get home, I have a sauna when I get home. And
there you go.
That's been wonderful. The sauna is so much better.
Amazing.
Than a beer.
Yeah. There's alternatives. Sure. There's lots of alternatives.
All right. One last question I have is, we're busy people. I would love to be able to spend lots of time preparing food. My wife has been part of the slow food movement in the past, where you spend a lot of time preparing food and eating slowly and enjoying it. And I wish I could be there, but unfortunately many of us have very time-pressured lifestyles. How do you prepare your food around shifts so that it's kind of easy, efficient, and healthy?
Yeah, so I think the key is actually preparing ahead of time. I prepare a lot of things ahead of time, and then I portion them out in containers and I put them in the freezer. I find the Instapot is great for creating a lot of low glycemic index meals that are cheap also. Beans, lentils are low glycemic index. They're filling. Easy, healthy snacks, like I mentioned already. They don't take a lot of time to prep, like slices of cheese and roasting some nuts and an avocado and egg and fruit. And actually, my favorite thing to do on shift is that I have a portable blender for making a smoothie. So I add things like protein powder, Greek yogurt, some sugar-free nut butter, fruit for the antioxidants, and then I add in the seeds that I mentioned earlier, like psyllium and chia seeds and flax seeds. And that just gives me a balanced smoothie that has overall lower glycemic index. And I charge up my blender, I bring it to work, and then in between, when in between patients, I can run back and kind of just blend, chart while it's blending, drink it, and then be back in action. So I find that works really well for me. It doesn't take a lot of prep time, but it allows me to feed myself even on shift with something healthy rather than reaching for, the popsicles that are in the fridge nearby.
All right. Thanks so much, Dr. Ng, for your contributions.
Thank you.
Hopefully our listeners will be able to just reflect on how they eat and when they eat and how much they eat and what they eat a little bit, and maybe just make some slight adjustments to their current habits, and hopefully that will help to make us healthier and reduce our chances of cardiovascular disease and cancer and depression.
If we were to do a quick recap, 1, eat during the day as much as possible. 2, be careful about what you eat after a sleep disrupting shift because you're more insulin resistant. 3, choose low glycemic index foods as much as you can. And lastly, eat high glycemic index foods sparingly and or pair them with fiber, fat, or protein. Hopefully these takeaways will help.